Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated.
Welcome, everyone. I'm Dr. David Miller, Assistant Professor of Medicine and Dermatology at Harvard Medical School in Boston. Today, I'm joined by my colleague, Dr. Basal Patel. Basal, always great to collaborate with you on these discussions.
Thanks, David. It's a pleasure and an honor. I'm Dr. Basal Patel, an Associate Professor of Dermatology and Medicine Oncology at the GW Cancer Center in Washington, D.C. I'm particularly excited about today's topic because basal cell carcinoma, especially in its locally advanced and metastatic forms, is often misunderstood and underappreciated when we discuss systemic therapy. And yet, it presents some of the most complex treatment decisions, conversations in cutaneous oncology.
Absolutely. Unlike melanoma, where systemic therapy is now standard in high-risk cases, and CSCC, where immunotherapy is a well-established option, BCC is still largely seen as a surgical disease. And while that's true for most cases, we now have systemic therapies that are changing the treatment landscape. So today, we're going to address one, where community providers may be missing opportunities to optimize care. Two, how multidisciplinary management improves outcomes. And three, the evolving role of neoadjuvant therapy and even bimodality therapy. So over the past couple of months, we've held 6 programs with community healthcare providers, primarily in non-academic settings, to get a real-world sense of how BCC is being managed outside of major cancer centers like the 2 that we practice in. And I have to say, the insights, well, they were kind of eye-opening.
Yeah, they really were. Many takeaways, many insightful viewpoints, lessons. And some of the biggest takeaways, one of them is that most community providers see only 1, maybe 2 patients with advanced basal cell carcinoma per month, sometimes even fewer. And that's not uncommon, but it's a key challenge because when you only see a handful of cases per year, it's hard to build an expertise on neurosystemic treatment strategies, let alone just a comfort level of how to approach these, think about these. Go through your treatment ladder in your head and come up with the script that you're going to have with the patient, the conversation script that you're going to have to try to hone in on what really makes sense for that patient and for you as a clinician to feel comfortable offering that to the patient. But more importantly, it also raises the question of what exactly counts as an advanced BCC. I mean, are we talking about the large neglected tumors, David? You know, some of the ones that we see in case reports, textbooks that we have learned about, or are kind of those pictures where people's jaws drop to the floor. And those are the hard cases to manage. They're the debilitating ones. They have lots of issues, not only medical ones, but psychosocial issues as well. And we have to navigate through all of that. But also there are those cases that are the smaller tumors, sometimes deeply invasive and functional, cosmetically sensitive locations, like the medial canthus, the nasal tip, the ear. These are the ones I'm finding myself more and more regularly having to deal with and having more challenges with. Well, which one of these is advanced basal cell carcinoma? Well, I mean, I think, David, you and I talk about this a lot. The answer really is it's both of them.
Both, right? Both. Yeah.
And because of that, I think that it is difficult for providers to think about which way they go with which type of cases, or can we clump them together? But what was interesting is that in these programs, I think most of the providers were noting that they consider the tumors that are grossly large and clearly unresectable the advanced ones. And I think that can create some kinds of problems as it relates to just how to think about treatment and care when we just take out the other side of that spectrum of disease.
Yeah, I totally agree. I mean, for BCC, it's not always about the size, right? It's about the biology, and it's like real estate. It's location, location, location. I mean, a 3 centimeter tumor on the scalp might be pretty straightforward for a talented Mohs surgeon like yourself, while a 1 centimeter tumor in the periocular region can be significantly morbid if treated surgically. So when we talk about defining advanced disease, we need to emphasize not just about the tumor burden, but really importantly about the functional risk. Another major issue we found, inconsistency in staging, right? Some providers use HACC staging, some use the Brigham and Women's staging or BWH staging. And perhaps not surprisingly, like not everyone's staged. But without a consistent framework, we can't reliably determine which patients should be considered for systemic therapy.
Exactly. As you noted, it's not surprising that many providers don't stage it at all. I'll admit, I'm not routinely thinking about staging the patients for every single basal cell carcinoma that comes in. Sometimes we say that maybe it's an academic exercise, but it's not an academic exercise.
I agree.
It-
Again, I have to think about when I was doing my general dermatology clinic, I definitely didn't stage every time I had a BCC patient. I'm not totally surprised by those findings.
Exactly. But it's important to also know that staging is key. It's one of the pillars of oncology as a field,
Great.
and it helps not only derive treatment decisions, it helps us understand as it relates to outcomes and to really be able to have that discussion with the patient. And if we don't consistently stage, we end up making subjective treatment decisions rather than evidence-based ones. And certainly, many of the providers, many of ourselves have extensive experience, and we have good subjective treatment, clinical judgment skills that we have, but we want to be able to quantify that and also then be able to provide that information to those providers who may not have as much comfort or experience. And when we don't stage, that can also lead to variability in the treatment recommendations. It may mean that some patients who should receive systemic therapy may just never be considered for it, while others who could still be cured with aggressive surgery and radiation might not be treated, or excuse me, might be treated with drugs when they don't actually need them. And the reality is, BCC staging is important, but it has limitations. And those limitations are ones that we discussed a little bit. And I think it is something that we need to highlight and bring more education and familiarity to.
Agreed. I mean, no staging system's perfect, but they do certainly have value. And that brings us to another striking point. Most providers we found had very little experience with systemic therapies, even though hedgehog inhibitors like vismodegib and sunitinib have been FDA approved for over a decade. These drugs were the first real systemic treatment for BCC, and yet many providers hadn't prescribed them or had even discussed them with their patients.
Yeah, that's right. And when we asked why, a few key themes emerge. Well, first, there's a perception that these drugs are highly toxic. And yes, we know hedgehog inhibitors do have side effects, the main three being muscle cramps, dysgeusia, fatigue. We know from multiple studies that there are ways to get around these side effects. You can utilize dose adjustments or intermittent therapy, which can significantly improve the tolerability of the drugs while maintaining efficacy. We've had these drugs around, as you've noted, David, for over a decade now. And with that time has come experience. And I think that many of the clinicians we spoke with, some of that experience has not really permeated out into the community. And that's a key point when it comes to getting clinicians familiar and comfortable with this, but also then offering that to our patients.
It's a great point. When I think about my own journey when I came out of dermatology residency, I sort of had this idea that hedgehog inhibitors or smoothing inhibitors, term I actually prefer, had limited value. They weren't curative. Was my impression, and they had a lot of toxicity. But Over the last, God, was it been decade plus, I've started to appreciate different strategies, like you mentioned, like alternate dosing strategies, and think that they are an important tool in our toolkit.
And I think that really is a not only a common theme for all providers, but also just makes sense. This is a rare disease. When we first understand these therapies, they come out from clinical trials. We are really focused on the science, the pivotal studies. There's this really stringent way they've been evaluated and the outcomes related to those studies, the side effect profiles that we see on the label indication. And so it, just as you experienced that, David, I think it's not surprising that maybe providers, when they're seeing 1, 2 cases a month or even fewer, they're just not familiar with that experience. It may be on the market for a decade and approved for that indication, but if you just haven't utilized it that much, we all know from our experience, those medications, those disease processes that we're comfortable with, we're able to tweak and apply that to the patient in front of us. So providers maybe not familiar with those alternate dosing schedules, they assume that patients won't tolerate them, and as a result, maybe not having that discussion or even offering that to those patients. But then beyond that, a second theme that we saw is there's some lack of clarity onto some of the newer treatments that are out there, and specifically immunotherapy, and when do we transition from hedgehog inhibitors to immunotherapy?
Important question.
Cemiplimab, a PD-1 inhibitor, now FDA approved for patients who progress or cannot tolerate hedgehog inhibitors. But many providers, particularly surgeons, weren't even aware that immunotherapy was an option for BCC. It's brand new, but it is certainly cutting edge and a game changer, and that's an important therapy to have in the back of our mind.
I agree. And it is a little concerning because we now have data that shows cemiplimab achieves an objective response rate in about a third of patients, including, importantly, complete responses. And, that's not trivial. That means we have a real systemic option beyond hedgehog inhibitors. But many providers, like you said, aren't necessarily aware of that, aren't comfortable prescribing it, or are not integrating it into their treatment discussions with their patients with advanced BCC.
Yeah, and to your point, David, I think this may highlight the lack of comfort or familiarity with just treatment guidelines in general. For example, the NCCN guidelines were mentioned as influential by many participants, yet there's still just a heavy reliance on surgery alone. It's the traditional thinking of basal cell carcinoma, certainly what has been utilized for many, many decades. And so it's understandable given that there's such a very high surgical cure rate in early stage disease, that these are the vast, vast majority of types of tumors that providers will see, that's where the natural inclination and the thought process goes. But for advanced cases, a single modality may not be enough for these patients.
So, Dr. Patel, what do you think the biggest gaps are right now? Is it lack of awareness of treatment options, over reliance on surgery, or something else?
I mean, I'd say that it's a little bit of both. I think we've kind of touched upon some of these themes and what makes sense from a historical standpoint and just from an epidemiologic standpoint of why these themes have become ingrained within the practice and the treatment approach for basal cell carcinoma. Surgery is often first and the only option considered, even in cases where systemic therapy and or radiation could be beneficial. Um, there's almost an assumption that other options should only be considered if surgery is not possible. Instead of, could a non-surgical or combination approach be equal or even potentially superior to surgery? I mean, I I admit that early on in my training, just as you noted, David, coming out of experience with from training with hedgehog inhibitors and having kind of a bias or a mindset around the toxicity profile, I came out early from fellowship and just thinking that these are all surgical tumors and that we really shouldn't even consider anything else because we can get such high cure rates. It's taken me over a decade to start to shift my viewpoint in term, just because we can do surgery, should we do surgery? And asking myself that question and certainly having that conversation with the patient. And, I think part of that part of this issue stems from that gap of understanding risk stratification for basal cell carcinoma, that it's a different tumor than SCC and melanoma, that What is the endpoint that we're trying to get? Is it the quote unquote cure, the clearance? Is it control? Is it a quality of life improvement? And then how do we then decide who needs escalation for that care beyond surgery?
That's a great point. And when we think about systemic therapy, there's an uncertainty about when to use a smoothing inhibitor versus immunotherapy. Many attendees we found weren't comfortable making those treatment decisions, which means patients might not be getting all the options available to them or in the optimal time. This is certainly an area to build upon and can point to the importance of multidisciplinary input or support for these decisions.
Absolutely. I mean, that's the other common theme that I think we talked about, and is so important and critical. Multidisciplinary management is critical. We know that involving dermatologists, oncologists, radiation oncologists, and even various reconstructive surgeons leads to better decision making, higher patient satisfaction, and most critically, improved outcomes.
Right. I mean, it is absolutely about building the right care team. Who should be involved? And how do we make sure treatment plans are both evidence based and practical for community providers?
And I think that starts with better communication between specialists. It's not just
Right.
about referring a patient out, because referring a patient out, but rather having a structured discussion that can be maybe through formal processes like tumor boards that we see in academic institutions, but can also be in more informal ways. There can be virtual tumor boards or virtual consultations with specialists that are far away from the main provider and where the patient is based. Or what I've been advocating and what we kind of discussed in some of these community programs is informal ways of doing that just amongst colleagues, having that network set up for you so that when you may see one of these patients, you know how to reach out for to have an open and comfortable conversation around maybe something that you're uncomfortable with or not used to treating so that you can optimize the treatment strategies.
Yeah. And, we talk a lot about multidisciplinary care, interprofessional care, but at the center of this multidisciplinary team is the patient, and incorporating the patient's voice is really critical in these situations. Shared decision making is important because it can help us understand the patient's value structure, their specific life situation, and the risks and benefits of the different approaches that are available, especially when we're trying to balance surgery, radiation, and systemic options.
And basal cell carcinoma is really unique in that way because oftentimes it's something that the patient has lived for a long time. It's potentially not as debilitating as some of the other cutaneous malignancies because it is more local than potentially having a systemic impact. As a result, understanding that value structure can really be key. And from that conversation, you begin to, I think, realize there are different approaches of obtaining that goal that the patient may have in front of you. And so it may not just be surgery per se. There may be a combination approach where you may utilize a systemic therapy initially, and then may consider surgery or a radiation therapy. And we are seeing that types of approaches in other cutaneous malignancies, the neoadjuvant therapy approach of using systemic therapies potentially earlier on, and either de-escalating surgery or even potentially avoiding surgery. And I see that that is a big piece in the big future in basal cell carcinoma. It has a growing role using these systemic therapies to reduce the tumor burden, potentially improve the surgical outcomes. But it's very early in the world of BCC, as opposed to a lot of the research and work that's come out in squamous cell carcinoma and melanoma. We still don't know a lot about this approach to BCC, particularly because, as we learned early on in the program, it's just not a very highly frequent disease that most providers, either in the community or in academic centers, are seeing. And so we've only really begun to study it, and it takes us some more time due to the lack of frequency of these patients. There have been small studies that have shown promise, but there's also some areas of potential concern in understanding the long-term control, potential recurrence risk, but it is where many of us, I know you and I, David, we're very excited about this. We're focused on this, and it certainly is the area for the future for BCC.
Absolutely. It's an exciting area for the whole field of cutaneous oncology, as you mentioned, in melanoma, CSCC, even in Merkel cell carcinoma. Preoperative immunotherapy has shown incredible promise. And I think we're going to see more, as you mentioned, emerging in BCC as well. The challenge will be ensuring that community providers are aware of these strategies, understanding their nuances, their limitations, and feeling confident in using them.
Yeah, and speaking of systemic therapy before surgery, I think it's worth discussing the potential role of combining smoothing inhibitors with radiation therapy. It doesn't necessarily have to be surgery. I know we've touched upon and we discussed in these programs how surgery is the cornerstone, the mainstay, but there's some exciting data around using alternative, non-surgical, approaches in a combination fashion. Recent Barker et al. Studies showed that induction vismodegib followed by concurrent vismodegib and RT led to a high local regional control rate of 91% at 1 year for locally advanced unresectable basal cell carcinoma. This is particularly important because RT alone, radiation alone, has historically had variable efficacy in this setting, and combining it with a smooth inhibitor may improve those outcomes. Also, from a practical standpoint, some of these tumors that are large or difficult to treat, the course of the radiation as well as the side effects of that can be challenging. But when we can combine that with the smooth inhibitor, potentially make that easier to manage and then have that more durable outcome, it is really why we are really excited about that as a therapy that community providers should be considering and thinking about and discussing with their patients.
That's a great point. It was an important study, published in JCO, and it not only showed really good response rates, I think it was like 63% after induction Vismo, 83% after the concurrent approach that you mentioned, but really importantly, demonstrated sustained progression-free survival. I think it was a median follow-up of nearly 6 years. The 5-year PFS and OS rates were, I think, 78 and 83% respectively. That's fairly meaningful durability and suggests that smooth inhibitors might not only shrink tumors, but also could work synergistically with RT in cases where surgery really isn't an option.
And that's really a key point. What you've noted there, David, is that many of us who use hedgehog inhibitors, we have concerns about recurrence, about the long-term tolerability, and what happens if we stop patients who don't have a complete response. Well, this piece of evidence really shows that adding a second adjuvant therapy can get us across that bridge in a highly durable and high sustained response rate. And yet, most community providers don't seem to be considering this approach. Many still see smoothing inhibitors and RT as separate options, separate backup options rather than complementary modalities. And the reality is that the patients with unresectable BCC, an upfront trial of smoothing inhibitors followed by radiation therapy with curative intent strategy should be a curative intent strategy rather than just a palliative one. And certainly I have began to incorporate that into my thinking in the last year or so, more so than I did in the past.
Exactly. And even beyond the oncological outcomes, there's also, most importantly, or very importantly, the patient experience to consider. The Barker study found that quality of life actually improved after combined treatment, particular in emotional and functional domains. It's critical because patients with these large, unresectable BCCs often experience significant distress, and knowing that their disease can be controlled effectively with a well-tolerated approach, can be thought of maybe as a game changer.
Absolutely. And I think the key takeaway is that systemic therapy, whether it's neoadjuvant, concurrent with radiation therapy, or part of a long-term treatment plan, needs to be better integrated into community care. The data are there. The challenge is making sure that they translate into clinical practice.
Dr. Patel, as always, this has been a really, really great discussion. I think we've highlighted some key areas where we can enhance care for the advanced BCC patient through better stratification, multidisciplinary collaboration, and increased familiarity with these systemic therapies.
Absolutely. The goal is to ensure that every patient, regardless of where they're treated, has access to the full spectrum of care options and an opportunity to discuss and learn about them, and also bring their voice to the table and tell us or tell their providers what's important to them. This requires ongoing patient and provider education, better communication between caregivers, and a shift in how we think about BCC management.
Thank you, Dr. Patel, and thanks to all of you for joining us today. We appreciate your time and your commitment to improving the care of patients with advanced BCC.